Good afternoon, everyone. Thank you for joining us today. We're joined by our friends and colleagues at OFMQ and MyHealth to discuss HIE implementation, as well as resources and opportunities available to your rural facilities. And with that said, I'm going to turn it over to Jason. As always, if you have any questions, please feel free to unmute your line or put something in the chat. We'll be watching the chat as well. If you're watching this recording and have any questions or concerns, please do not hesitate to reach out. With that said, Jason, I'll turn it over to you.
Okay, thank you, Laura. We appreciate this opportunity to get to speak with everyone today. My name is Jason Feltz. I'm a health IT manager at the Oklahoma Foundation for Medical Quality. We also have Ashley Rood on the line. She's another HIT manager with us. So we have partnered with MyHealth to help them with outreach and onboarding for enrollment for the state health information exchange. So I'll kind of give a little bit overview of where we're at with the HIE in the state, how you can get connected if you're not already. And then we've got Dr. Kendrick on with MyHealth, and he'll kind of give you an overview of their products and services and just the different things that they can do for you and help you in your practice. And then we'll open it up for questions and just about the program or about MyHealth products in general. Okay, so kicking us off, hopefully everybody is familiar with the term HIE or Health Information Exchange. If not, right now here in Oklahoma, we have OKShine, which is the State Health Information Exchange. So in 2023, Oklahoma legislature passed a bill that empowered providers and organizations to create a more complete patient record in the state designated health information exchange. So that part, state designated, is important. When they came out with the idea of the state HIE in Oklahoma, it was named OKShine. So if you hear OKShine or you hear MyHealth, those two terms really relate to the same entity or organization. So MyHealth is the state designated entity for HIE in Oklahoma. So there was a $30 million legislative appropriation. What this is for healthcare providers, hospitals, clinicians of various types, long-term care facilities, pharmacists, just a lot of different providers across the spectrum can connect to the State Health Information Exchange. And with this funding, have their connection costs to MyHealth covered. This funding is only guaranteed through June of this year. So it's really important that if you haven't already, you get on the list for that connection fee assistance. And so this is, again, for any organization that employs licensed healthcare providers in the state of Oklahoma. This program is called the Connection Fee Assistance Program. Sorry, did someone have a question? Okay. So to apply for the Connection Fee Assistance Program, right now you can go to this website, and again, we'll send out the slides after, and click on the Connection Fee Assistance application. The first step of this is you have to have completed an application for MyHealth. So if you haven't done that, that will be the first question. If you say no, this site will kick you over to the MyHealth site to get registered on that side. If you've already registered with MyHealth, then you can fill out the Connection Fee Assistance application and get rolling on that side. So once you've done that, that kind of puts you in queue with the OFMQ MyHealth team to reach out to you to find out more specific information about your organization, your EHR, your setup, have you contact your vendor and get things going on that side, and then really walk you through that connection process, talk to you about the products that MyHealth has available, and which ones would be best for you in your practice. Again, this does pick up that integration for MyHealth on their side. So again, this is only available through June. That could be extended further, but as of right now, that June 30th deadline is what we have for this program right now. And this, again, is something that we really recommend that you do now. So if you've kind of been on the fence about connecting to a health information exchange, if you think it's something that, oh, we're not quite sure if we're ready for it, but we may do it in the next year or two, now's really the time to do this while you have this funding available. So we're talking of possibly tens of thousands of dollars in interface fees that could be covered for your organization now, that may not be available in the future. So really great opportunity for you to get connected at this point. This is a list of current members connected to the MyHealth Network. And I will now kind of let Dr. Kendrick start to chime in and kind of give a little bit more of an overview about MyHealth. And then after that, we'll kind of get into how MyHealth can help with the regulatory side of things, and then which specific products will help you with that. So Dr. Kendrick, I will turn it over to you to introduce yourself.
Sure. Thank you, Jason. Great job with the introductory overview and the kind of the call to action. As you guys know, anytime the legislature is in session, the unknown can happen and things can happen with funding in that. So we want to make sure everybody reserves their spot for both the connectivity fee assistance and then another program we'll talk about later called directed payments. So just to sort of clarify, so MyHealth is a nonprofit organization in Oklahoma. It was created by providers and health plans and tribes and other healthcare stakeholder organizations because we recognized we didn't have a way to securely exchange health data with one another, and that we were really going to need to do more of that as value-based payment models came along, as managed care came along, and so on. And so as we are, MyHealth was actually founded in 2009 and 10. I guess we were incorporated in 2010. Currently covers between 85 and 90% of all the health data in the state, but that obviously is contained within the larger health systems, mainly urban organizations. And we're really now hoping to be able to provide value to rural communities and get rural communities connected to MyHealth. Now, that said, there are a lot of rural FQHCs and clinics and hospitals that are already connected, but we definitely want to make sure that we extend these services everywhere. It's like, and I will introduce kind of a new term here. We use the word health information exchange to describe what we do, but it's both a noun and a verb, so it can be confusing because your electronic health record vendor might say they also do HIE, like you might be on Epic and use Care Everywhere, or you might be on, I don't know, Cerner and have Commonwealth. Those are a different thing from what MyHealth does. MyHealth is more of something we now call a health data utility, right? So if you think about you couldn't really see patients without electricity or water. This is also the notion that it's really difficult to see patients if you don't have access to their full medical history, or knowledge that your patient was just discharged from the hospital, maybe in Oklahoma City or Tulsa in the last 24 hours. So this is the notion, the creation and evolution of MyHealth is the notion that now we have a health data utility that you can connect to and make sure that you're delivering comprehensive care where it's needed and when it's needed for your patients. You can see the members on this map, lots of types of organizations, ranging from hospitals and clinics to behavioral health providers to pharmacies, long-term care, essentially anybody that you can think of as a stakeholder in healthcare is a participant in MyHealth. Next slide. So I'm going to get Jason's help with this, but I'll just introduce this to say that in addition to helping us deliver better care and higher value in healthcare for our patients and their health plans, et cetera. Part of having a health data utility and network like MyHealth is to help everyone also meet their regulatory requirements. Jason, I don't know if you want to take this or if you want me to go through it, but I'm happy to do it either way.
Yeah, so I can jump in and elaborate a little bit. With all of the different grant programs that OFMQ does, we always like to emphasize, what the benefit is going to be for your patients, but also what can your office, what can your organization get out of it as well. So MyHealth can really help a lot on your promoting interoperability and quality reporting side of things as well. Within the promoting interoperability program, there's a couple of different objectives and measures. One of them is health information exchange, and the other is public health and clinical data exchange. So with the health information exchange, this has been around throughout meaningful use with promoting interoperability. It's a way for your healthcare organization to send data securely and electronically to another healthcare organization. In the past, this was typically accomplished, if you could accomplish it through direct messaging. This was kind of like a secure email, but finding out people's credentials and how to send it and who even knew about direct messaging was really a problem. So the idea of the bigger picture of HIE is really helpful here. So right now with this health information exchange objective, you still are reporting on the information that you're sending and receiving electronically from your organization. There's 3 different options to be able to report that now. One of them is still submitting those measures from your EHR system that shows the total number of patients that we transitioned out of our care, and those patients that we downloaded that CCDA and sent electronically through a HIPAA secure means. And then also you're in turn submitting another report on the number of transitions of care that you have inbound, and then reconciling that information. So medications, allergies, and problem lists. So that first option, you can still report data, 2 different measures, numerator and denominator. What's really helpful is if you're connected to MyHealth, which is a bidirectional HIE. For this objective, you can just say, yes, we're connected to a bidirectional exchange, and you get the full 30 points for that measure. This is much easier than having to submit the data out of your EHR. It's also a lot easier on the audit side because MyHealth will give you a letter that shows that you're connected with them and meets all the specifications on this side. So really big benefit within this promoting interoperability program for you to be able to get a lot of points with the capabilities that MyHealth has. And I'll turn it over to Dr. Kendrick here in just a minute after 1 or 2 more slides to talk more in depth about their specific products that they have that can help you with this. So 30 points for that HIE measure. And then another one that MyHealth can help with is your public health and clinical data exchange. So both clinicians and hospitals have to submit to public health and clinical data registries. MyHealth currently has a COVID registry that you can connect to that would get you those 5 additional bonus points. They also may have additional registry capability that can get you other points. And then there's potential to be able to connect to the state health department and submit immunization data and other public health data in the future. Just several different options and things that MyHealth can kind of step in and facilitate that process for you instead of you having to have several different connections. The one last piece that I'll talk about and then turn it back over to Dr. Kendrick is social determinants of health. So for hospitals, there are new requirements on social determinants of health screening that you have to screen individuals for health-related social needs. Those 5 health-related social needs are included here. You're going to have to report how many inpatient individuals you collected this data on, and then how many of them screened positive for one of these health-related social needs. So MyHealth actually also has another social drivers of health tool that can collect this data for you, and again, just facilitate that process and make it easier. Dr. Kendrick, I'll turn it over to you to talk a little bit about your SDOH process in MyHealth.
Yep, absolutely. So, one of the keys, I think Jason did a nice job of covering some of the regulatory obligations that we all have as healthcare providers and organizations. And among them now, the social needs are really becoming more prominent, and recognizing that gosh, I guess in 2016, MyHealth applied for a program called Accountable Health Communities, which was a CMMI demonstration project with the Medicare and Medicaid population. And as part of that, we recognized pretty early on that it created a lot of burden to have yet another set of screening questions to do at the beginning of every visit. We're already doing PHQ-9s for depression and GAD-7s for anxiety, and now experts maybe for substance use. And to add another one, even though we all agree these are very important questions and they can really impact the patient's care, there's just not more time and not more staff available to do that. So that when we went to the community and across Oklahoma and then asked emergency rooms and clinics to deploy the screening instrument, which I think was about 12 or 15 questions, everybody said no. They said, love to do it, there's just not time. And so MyHealth actually pioneered the development of a new process that's driven by the electronic exchange of information, so that any organization that's connected to MyHealth with an ADT feed, which is stands for admission, discharge, or transfer feed. It's very common data feed to come from clinics and hospitals, especially hospitals. If you have a live ADT feed, then MyHealth can turn on a social needs screening that goes back to your patient's mobile phone while they're in the waiting room. And you can effectively offer the screening to all of your patients. And if they have a social need, MyHealth also has a directory of social services that we can choose from to offer an immediate referral back to the patient. Let's click on the next slide. Take a look at that screen. So here's what on the left is what the screening question looks like, and the next slide shows what the need might be. I'm sorry, the next sort of screenshot there, phone screenshot, and then the third phone screen there shows what a referral would look like. And so if a patient, for example, reports a food need just on their mobile phone when they answer, then MyHealth, we look in the community resource inventory, we have 5,000 resources listed there. We look for the nearest food bank for the patient, something closest to where they live or walking distance, and then we we offer that, but we also offer a food pantry, which might be a more substantial service. And then finally, Oklahoma SNAP program has collaborated with us to give us a link to an online application form so that the patient can get not just their immediate food need met, but also longer term support and services through SNAP. And all of this has occurred while the patient is still in the waiting room and before they've even been roomed to see the provider. And so the goal of this was to create with almost no burden on the community, the clinic or the ER, to still be able to offer universally to all patients the ability to get their social needs met. And this platform currently enables all of the items Jason talked about to be covered: food, housing, transportation, domestic violence or safety, as well as public utility needs. And we're now, I think we've offered 4.5 million. We've offered the screening to patients in 4.5 million visits across the state. So it's pretty well used, has had a big impact, and it's included in the base service for MyHealth. So if you're a participant in MyHealth and you have the data feed needed, then we can turn this product on for you. Next slide. Go ahead, Jason.
I will chime in and say that Medicare doesn't require you to use a specific tool. They do recommend the Accountable Health Communities tool, and that is what this tool is built off of. Correct, Dr. Kendrick?
That's exactly right. I'm glad you pointed that out. The instrument we offer here qualifies for Medicaid, but also for Medicare's MIPS program, as well as HEDIS measures. So if you're dealing with health plans who are interested in you working with them on social determinant screening or social needs screenings, then this metric qualifies for that, as well as Joint Commission if you happen to be accredited by the Joint Commission. Thank you. Next slide. So the beating heart of MyHealth from an end user perspective is the provider portal. And that is a place where your providers, your care managers, others who engage with patients can log in and be presented with one summary version of the patient's chart. And it includes all their visits, all their medications, their allergies, lab results, vital signs, discharge summaries, H&Ps, op notes, all of that information already organized into the patient's chart here in the provider portal. It is web-based, so you go to a web browser to access it. And we also at MyHealth offer the ability for organizations to have a single sign-on embedded in their EHR, because, you know, speaking as a provider myself, it's kind of a pain if I have to leave the EHR and go log in on a separate web page, although I will do it to have more complete information and to know what the best next steps are for my patients. It's easier if I can have a single sign-on embedded as well. So we offer that for organizations who would like to deploy single sign-on. One thing I would say about this, if you're an organization that's maybe connected to eHealth Exchange or Care Quality or Commonwealth, maybe one of those so-called national interoperability models through your EHR vendor, there's some important differences between those and what's available in MyHealth's portal. Typically, those programs allow you to request documents on the patient from a specific location, but in order to do that, you have to know where the patient went for care. You have to know when they went there, and so on. And so the data in the MyHealth provider portal is all pushed there. So just as we will connect to your organizations, and as care occurs, it gets pushed into the MyHealth system. That's also the case for all the other participants, as well as for hospitals and clinics connected to other networks around the country like MyHealth. So I'll tell you more about that in a moment. But essentially, if you go to MyHealth's portal, we don't just list the documents where you have to open and read all the documents to find, I don't know, the latest hemoglobin A1C or the latest blood pressure. We digest all of those documents so that there's a common medication list of all medications. There's a common allergy list of all allergies. And the same is true for lab results and notes and other things. So it's a bit more intuitive, just a one-stop shop for records, and they're summarized already for you in that place. If we have time today, or if people are interested, I'm happy to log in and demonstrate how the portal works if folks want to see it. Next slide. Well, I should say the data in that portal is available pretty close to real time. Yeah, there's a screenshot of it. Again, I'm happy to log in if you'd like, and demonstrate it for you. But what you see there under the dark blue bars, it's a little hard to read, but each of those is a list, like all of the encounters, or all of the notes and documents, or all of the lab results, and so on. Next slide. So speaking of the portal, what's in that portal? The data feeds that we build from organizations. So what would we connect to from your electronic health record system? I already mentioned the admission, discharge, transfer messages. Certainly health systems and hospitals can provide those, and most clinics can, although not all. And that tells us everything about when the patient was registered, when they were roomed, what bed they went to, when did they get transferred to another facility, and what facility was it, as well as discharges home. And those are all critical events to know about if you're responsible for the management of care of a patient in your community. Then there are ORU, those are lab results. ORMs, those are orders, medical documents, patient problem lists, treatment orders, pharmacy dispense events, vaccinations, and then something called consolidated clinical documents, or CCDs. Those are like a summary of the full patient's chart, and we take those in as well. And again, we receive these are sort of computer readable documents, and we digest them into a human readable presentation we put in the portal. And the process of building these data feeds from your organization is covered by these connection fee costs from the state, because that can be kind of expensive, $5,000, $10,000 per organization, or even more. And so again, just would encourage you to go get that connection fee covered by applying for that connection assistance award from the state. Next slide. I mentioned single sign-on a moment ago, but that's also something that can be covered by the Connection Fee Assistance Award. And that's how we work with your vendor and your technical team in your clinic or hospital to get that single sign-on button implemented, so that it's really easy to get out to the MyHealth record. and review it, for your ER doc on the front line or your care managers as needed to have pretty immediate access to the comprehensive chart. Next slide. So, with all of this data flowing into MyHealth, into the network, we also realize that, it's not always obvious to me if my patient's being admitted to the hospital across the state somewhere. I may not even be aware or have received a call from them. And so MyHealth provides a product called Care Fragmentation Alerting that you can subscribe to that lets you know every morning with a report of all of the visits that your patients have had in other places, whether they were admitted, had an ER visit at a hospital outside of your area, whether they were admitted to the hospital or discharged from a hospital, whether they showed up at the dermatologist office that you referred them to, whether they made it to the cardiologist office. It's basically a map of everywhere your patients have gone in the last 24 hours so that you can stay on top of managing and coordinating their care and services. And especially for those of you in rural communities, I know I grew up in Duncan, which is somewhat rural, not the most rural place, but it's certainly not Oklahoma City or Tulsa. And I can remember vividly, as a patient myself or with family members, once we were sent to Oklahoma City for care, sometimes the treatment relationship shifted to that urban provider. And this care fragmentation alerting is a good way to make sure that your patients come back home, to come back to your community when they're ready to be seen and follow up in their primary care clinic or in whatever care relationship you have existing to retain that relationship and ensure that you're providing the next thing this patient needs when they return home. It's also a good way to follow the progress. If you have a patient who is transported for emergency reasons or for management in a more acute care setting, so you can follow daily what's going on with this patient in the ICU or on the hospital floor, maybe at OU or at Integris or at St. Francis or somewhere far away from maybe where they live. So you can, again, know and be ready to catch that patient when they come back home and get them reintegrated into care and services. And this also has, obviously, while it has huge implications for the quality of care and the ability of a patient to return home to the regular treating providers, it also has financial implications for those providers, because as you well know, for especially Medicare patients, having a follow-up visit, a timely follow-up visit after discharge reimburses an extra amount. And also local hospitals, if you were the admitting hospital originally, you may be at risk for a 30-day readmission, for example, or other potential penalties that you can get on top of by having these care fragmentation reports available at your fingertips every morning on your patient population. And I don't know if we said this at the beginning, but we're happy to take questions along the way. If you would like to chat in questions along the way, we can answer those as well. I don't know that I have the chat visible here, but I'll make it visible in case anybody has questions. All right, next slide. All right, so care gap reporting is another product that we think can be helpful, especially in rural communities. And a care gap is any preventive care or service that a patient needed that maybe they haven't yet received, or that they've received the testing elsewhere. And it's not always obvious, especially speaking as a primary care provider myself, it's not always obvious to me when my patients had a mammogram or a colonoscopy done, unless the gastroenterologist forwarded me the results, which they often don't think to do. And so that data is in MyHealth and is sent to MyHealth in real time as those tests and imaging, et cetera, are performed. The latest blood pressures and A1Cs may be there as well. And so we provide a reporting product to those who want it, where every day or every month or so, we will crawl through the data on all of your patients and identify the latest events that are relevant, like the latest mammogram or the latest colon cancer screening or the latest A1C test, so that you can know, especially if you're in a value-based payment model or you're trying to improve your performance on certain quality measures, that you've already met those requirements, or that you've got certain patients that need a follow-up to get their blood pressure under control, or their diabetes under control, or their prevention done. And so this report, again, is something that can be subscribed to. And I will say that the data that's in this report has recently been used to help some large health systems dramatically improve their performance on quality measures, for example, and could be helpful to you as well. You know, one of the big challenges that I perceive, at least in providing healthcare in rural communities, is that you may not have a large IT staff, and you may not have a large team that can spend all their time digging through the data to identify opportunities for quality improvement or to improve quality along the way. And so MyHealth wants to be a partner with all of you to help you play taller, to help you have that team. And care gaps is an important component or tool that you can use to improve that performance. Because as we all know, value-based payment models are coming, not just through Medicare, but also Medicaid now with the transition to managed care. It won't be too long before, if you're not already hearing from health plans that they'd like you to provide quality measures, or they'd like you to engage in a risk-based contract. All of that has to do with your ability to detect and measure quality, and that's something MyHealth wants to help you be able to do in your community without having to hire a whole staff to run analytics and provide your own quality measures, for example. All right, next slide. Another component of the services that MyHealth offers, and this will be especially applicable to hospitals and inpatient mental health facilities, you may have heard of the condition of participation requirement that Medicare now has, that when you admit a patient to your facility for ER visits or inpatient admission, discharge, or transfer, there is an obligation that you notify the primary care provider or the referring long-term care facility that you've admitted, discharged, or transferred this patient. And it's not always obvious who the primary care provider is. It's not always obvious who the long-term care facility is. And it takes extra steps when you're registering a patient to make sure this goes well. So MyHealth offers this as a service to hospitals and inpatient mental health facilities that are subject to these requirements. And again, when I say condition of participation, that's exactly what Medicare means. They don't, as far as I know, they've not done auditing on this yet. But when they begin to do auditing on it, and a hospital's ability to participate in Medicare will depend on having this service in place. So we think it's a fundamental service that everyone needs to have, and MyHealth can bring it to your organization as part of your participation in MyHealth. And essentially, we send direct, secure emails or those care fragmentation alerts, as you saw earlier, to those primary care providers and long-term care facilities to help meet this notification requirement. Next slide. So that's sort of a high-level overview of some of the products and services that MyHealth offers. I can tell you, and probably should tell you, a bit more about how MyHealth's pricing works. MyHealth is a nonprofit organization, and so we have to generate enough revenue to sustain the network, but it's not like we have shareholders or stock price we have to optimize. So MyHealth prices are set by its participants, and you all, if you become participants in MyHealth, will be invited to engage with governance. And we have clinical quality committee, we have a social needs committee, we have a finance committee where pricing is discussed, and you certainly would be welcome to participate there. But the framework for the way pricing happens in MyHealth is to be driven based on the unit of value for the type of organization. So for example, hospitals pay based on their number of adjusted patient days. Clinics pay based on the number of prescribing providers that they have. And there are other types of models, as you might imagine, say long-term care or SNFs would pay based on average daily census and other metrics like that. And then once you pay your base fee to MyHealth, then you're able to elect those other products because you get a credit for those products. So for example, the social needs screening doesn't actually cost anything. So if you're a participant in good standing, you can just say, hey, please turn this on for my clinic or my hospital, and we'll do it. Now, if you want us to deliver to you the results of those screenings, then you would elect that product and it will come out of your credits, or can come out of your credits. Care fragmentation alerting, you can use credits for, as well as the other products. Once you apply to participate in MyHealth, all of this information can be shared with you, and our client services team, as well as the OFMQ team, can walk you through all those options. We want it to be really easy to engage. We want you to get immediate value. Generally, that means getting you on the provider portal as soon as possible, so you can start to understand sort of all the other places your patients are getting care, and how best to coordinate that from your community. What other things have I not covered, Jason, that might be of interest to the group, or anyone who might have questions here?
Yeah, I think you've given a great overview. I'm monitoring chat to see if any questions come across. And I would just say, Dr. Kidrick and I have had conversations. I've been with the OFMQ for 14 years, and when I started was the swing of the HITECH Act, and everybody was moving to electronic health records, and we were talking about this idea of HIE back then. And we're finally to the point now where Oklahoma has put funding behind that. It feels like gone through this process with voucher programs, and it's a requirement, everybody has to do it. No, it's not a requirement. And so we've shared all of these concerns with the state, what it's going to take to get providers to buy in, and they've really stepped up and come to support that. So I think this connection fee assistance program is a great way for people to get connected. And again, there right now is nothing to lose. That funding is allocated through the end of June. If you sign up to participate with MyHealth, go through all the connection fee assistance approval, and then at that point decide, oh, this just isn't going to work out, you don't lose anything. If you decide 6 months from now, hey, we should really do that connection fee assistance approval program, we're ready to roll with MyHealth, that funding may no longer be there. So really now is the time to strike. And not only does MyHealth bring a lot of value to your practice and to patient outcomes, it can, again, help you check a lot of boxes with regulatory processes, just make a lot of those communication processes easier with other healthcare entities, with public health reporting. So just a really good opportunity to streamline in a lot of different areas.
That's great. And you remind me of something that I should have added before. Again, please, people, chime in with questions if you have them, and we'll take this conversation where you'd like. But there is an additional program if you're a Medicaid provider of a certain licensure or a certain degree type, so MDs and DOs and social workers and licensed professional counselors and a whole range of providers. We can get you more details on that if you're interested. You're eligible for a 9.5% payment bonus on all of your Sooner Select billing from those providers to if you are a participant in MyHealth and in good standing, and if you've at least made some progress towards a data feed, like having your application in for the connection fee assistance. And that's a lot of funding. The state has put around, by their report, around $60 million behind that incentive program. And by our calculation, for most clinics, it will more than pay for the cost to participate in MyHealth. So it becomes almost a profit opportunity for a clinical operation, especially if you're a Medicaid provider. And it doesn't take very many Medicaid visits, honestly, to offset the entire cost of the program with that incentive model. Hopefully folks have heard about that program. It's called the Sooner Select Provider Incentive Program. It will begin, the first payments will happen this July for, going all the way back to April 1. And if you sign up quickly and get through the process, the CFO at the Healthcare Authority is committed to paying those incentive payments going all the way back to April 1, even if you weren't officially a participant in MyHealth as of April 1. So But that is a closing window for the first quarter's payments, and those payments are first come, first serve as well. So for rural health clinics who receive the all-inclusive rate, those organizations are excluded from that incentive program, but not from the Connectivity Assistance Award. So you can still get your connectivity assistance. And for this year's directed payment program, I should have said that at the beginning, the Healthcare Authority can do a new directed payment program every year. This first year is focused just on organizations that don't currently have an all-inclusive rate. So that means it excludes like state employed providers, it excludes rural health clinics, it excludes tribal, and it excludes federally qualified health centers. Now, if there is care provided by that doctor or social worker or whatever through a hospital or through another entity that's not excluded, then those payments can receive that 9.5% incentive rate. And the total incentive is 28%. So it starts to quickly exceed commercial reimbursement rates if you have providers. And we're finding when we look in the data, we see that some, just take me for example, some of my care might be delivered in an entity that's excluded because of the all-inclusive rate. But if I work in an urgent care or emergency room or do any work in the hospital, those billings would still be eligible for that incentive payment. Great question. Thank you for asking. Any other questions? Can I ask you all a question? What do you view as the biggest barrier to participating in this health information exchange, health data utility opportunity? Is it technical barrier? Is it financial? Is it there's just too much going on? Complexity? What do you guys perceive as the largest barriers that folks might face? I don't see any coming in, but please do. If you can report on any of those, please chat them in. We are aware, for example, in some cases that EHR vendors will charge for the connection fees, and we're working with the state to try to get those connectivity assistance award to also offset those EHR vendor costs. Any other barriers you guys would mention? Getting the provider buy-in to use the portal, I agree. That's one that somebody mentioned to me. I think speaking for myself, it really took using it a couple of times to understand just how valuable it is to, it's really easy for me to think, and I'm speaking for myself and myself alone here as a clinician, to really believe that I'm the only provider involved in this patient's care. But in reality, patients in Oklahoma have records in an average of 4 different places. And that means they've got 4 different treatment relationships. And it's difficult to provide comprehensive care without it. And so seeing it in that provider portal is often one of the best ways. If you can get the single sign-on deployed as well, which again, the connectivity fee assistance will pay for, then that really reduces the effort it takes to go look at those records. I will also say that the staffing around the provider, as you well know, are important to this. So, sometimes having the nurse or having the person who rooms the patient pull the chart and even, print it if you have to get it in front of the provider the first time can be helpful in letting them know it's there. But I can tell you that definitively I have completely changed treatment plans based on what I see in the provider portal on patients. And that happens in almost every clinic session. So another item I see posted here is small hospital, small staff, late notice, limited time to get this done. All acknowledging all of those. Yes, definitely. What I think both Jason and I would want to emphasize is do the small steps that hold your place in line. At least do the online application to MyHealth, which is quick. It's just a few questions, and the connection fee assistance, which is also quick. I think it's like 5 or 6 questions. One of them will be your organization's tax ID number, just so you can have that ready. And then your place in line is held for these things. And we'll move as fast or as slow as you guys need us to once you've put your marker on those two items. So really want to encourage folks to get those 2 steps done as quickly as you can, and then we'll work with you to continue forward.
And to add on to that, Dr. Kendrick, say you're a hospital and you're planning on switching EHRs in the next 6 months. So you don't want to connect to MyHealth right now. Again, go ahead and fill out the application and fill out the connection fee assistance just to hold your spot in line. So we can document all of that information in our system and, you know, delay your integration onboarding until you get that EHR process done. So really the application process is easy and doesn't take much time. And then like Dr. Kendrick said, we can work kind of as fast or as slow as you need us to.
Good question asked about, I've been using the HIE for a couple of years now, been clients, been notified we're eligible for funding, but haven't received any yet. That is true. The first, let's see, I'm going to take it in 2 pieces. If you've applied for it and have the connection fee assistance award, then the money won't flow through you, but you won't receive a bill for any of the connection work from MyHealth. Your bill will just be covered by the state. If you sign up for the directed payment product, which is something you actually actively have to elect on an order form, that's the 9.5% bonus payment. That is one you need to reach out to MyHealth and ask for. You can email me. You see an email address there, and or Jason. Probably going to be better off emailing Jason, honestly. You know what it is when you email a doctor. But in any case, you are eligible for those directed payments, that 9.5% bonus, but you need to just check the box on an order form so we know to track and report that on your behalf to the state, so that they can make those payments to you. And again, best place, just to answer your question more clearly, the best place to start confirming that information is to email Jason at the address listed here on screen.
Yeah, if you'll shoot me an email just with your name and what facility you're with, we can search everything on our end, and then we'll reach back out and let you know where you currently stand in the process, and if there's anything else you need to fill out, or if there's something that we're waiting on.
What else? What other barriers? And let me know, do any of those things I mentioned in the sort of the value proposition resonate? Like, you know, patients getting transferred to Oklahoma City or Tulsa and just never coming back for care, leaving the community entirely for their care. Any of that still happen? I used to see it all the time when I lived in Duncan. We really want to make sure that the rural communities are supported with good, tight data integration and exchange with urban providers, but not so much so that people can't stay, you know, living in rural communities and get all the care they need there. Any other questions or topics folks would like us to touch on?
And if you don't want to come off mute or you think of something later, again, feel free to shoot me an email. We can answer questions about the Connection Fee Assistance Program, about the MyHealth application, more information on specific products, any of those things we're happy to help with.
Well, and since we've got a minute, I forgot or didn't know if we'd have time to discuss. There are a couple of other services that MyHealth offers that I'll just mention to you. Without doing anything, just, you know, being fed into our system, MyHealth is part of a national network called the Patient-Centered Data Home. You may have heard the concept of the patient-centered medical home, which is kind of a primary care concept. And the Patient-Centered Data Home is a program in which all of the data from around the nation that is happening in healthcare visits for people who live in Oklahoma but happen to be out of state for their care. Maybe they've gone down to MD Anderson cancer treatment, or they were on vacation in Arkansas or California and wound up in an urgent care or an ER. That data gets pushed back to Oklahoma through the patient-centered data home network. So if you subscribe to this care fragmentation alerting report, don't be surprised if you open it up and find that you had a patient admitted in Kansas or Arkansas or Texas overnight that you need to follow up on, or maybe have an opportunity to provide additional data on to that hospital. It was very interesting during the COVID pandemic to be able to see, as we had to transfer patients out of state because of capacity in our own facilities, that we could keep track of those patients as they moved around the country from place to place to get changing levels of care according to their need. And then also confirm that they've been able to come back home at the end of their disease. So. One other item that has come up recently, sadly, but it is true. You've probably seen the news on how many cyber attacks have occurred, ransomware attacks of hospitals and clinics, and I know everybody's very nervous about those things, and that's a scenario where MyHealth has won a lot of expertise, and we've been exchanging Oklahoma's health data securely since 2010 without incident, and that's because that's a core focus of MyHealth. We have a whole team dedicated to compliance. We're in it's called a FedRAMP, high trust certified environment with the data. The feeds we build are secure, and that enables us to act almost like a backup system to hospitals and clinics. So at this moment, as we speak, organizations that have had to turn off their own electronic health records or remove access to them because they were hacked in some way, they can continue to see patients and are doing so by having access to the portal in MyHealth. So it's become sort of a lifeline for those clinical organizations to be able to continue to deliver care and services even when their IT shop has had to take things offline. So keep that in mind as you connect. We have a very intense focus on privacy and security. We carry a large cyber liability insurance policy at MyHealth, and we recognize our role in maintaining security and have a very good track record there, and can be a partner to your organization and enabling you to have a higher level of security as well, rather than having to build lots of custom data feeds out of your organizations to all your vendors. Some organizations choose to just have MyHealth as their only outbound feed, and then we connect to vendors for them. So those are other things we can do to help out. All right, well, we've used a lot of the time here. If there are no other questions, Jason, did you have anything else you wanted to cover? Is anybody else on the call have anything you'd like us to delve into?
Yeah, I'm not seeing any more questions come across, so we appreciate everyone's time. And again, don't hesitate to shoot me an email just with any questions you have about any of the programs or products we discussed today, or if you're just not sure of where you may be at in the process, we're happy to help with that too. And a big thank you to you, Laura, and the Office of Rural Health for setting this up for us. And they've also been a great partner. We are working with them on the OFMQ side. We can help provide support with quality reporting, case review, compliance, some other things. So if you have just any needs in any of those spaces, we're happy to help.
Absolutely. Thank you so much from the MyHealth side as well. Anything we can do to help with your work, it's super important to make sure that folks can live where they choose to live and have great access to healthcare. You guys are making it happen.
Hey, thank you guys. Thank you all for such a great presentation. If you have questions after we get off the line, I will be sending out the slides. This will be posted online on our YouTube channel. But if you have questions, feel free to email me. I will forward them on to Jason and David. So thank you all for your time, and everyone have a great rest of your day.
Thank you all.
Thank you.